Hello everyone, this is Chadi Alraies from CVI 2022. I'm privileged today to be with Dr. Arnold Seto. He is Medical Director of the Cath Lab at Long Beach VA, as well as he is the Sky Treasurer. Arnold, always nice to see you.
Yeah, great to see you again, Chadi.
Yeah. So we have a nice session together about physiology, and we know there is underutilization of physiology in the Cath Lab across the country. We're going to talk about barriers first, and then we'll go some techniques. So what do you think we're not using it?
So actually the data, at least Philips came up with some data suggesting that of the intermediate lesions, that FFR was being utilized 69% of the time. And so they actually felt like amongst the vessels that require FFR, that require physiological assessment, meaning the intermediate lesions 30 to 80% or 40 to 70%, that actually were doing pretty well. So they were pretty pleased that even though the overall FFR utilization is 9 to 10, 20% at most, in terms of the appropriate utilization, they're pretty happy. The VA data from Bill Fearon demonstrated that at least in the VA sections, they had about 70% utilization as well, 70-80% utilization of FFR or IFR in the intermediate lesions. So it really depends on how you look at it. It's a glass half full, glass half empty thing, but I think from a standpoint of overall utilization, the companies are pleased. From a standpoint of appropriate utilization, it seems like the consensus is there that it should be utilized. So physiology should be utilized for all intermediate lesions when you're unsure of whether it needs to be stented or not.
Absolutely. So, and in the session we talked about also how physiology help you differ more in patient with intermediate lesions. So is this a good thing? Is it a bad thing? Are we doing the right thing? Or
say that again, I'm sorry.
We differ more when we do physiology.
Yes, so this is always the complaint about physiology versus imaging guidance, that we know that if you use imaging guidance, you'll tend to use more stents. If you use physiology, you'll defer more often.
Yes.
And so it's interesting, right? In England, they advertised the Defined Flare study as saying, look, IFR caused fewer stenting than FFR and had the same clinical outcomes. Therefore, that's a benefit. And it's just interesting that same thing here, IVUS versus FFR. FFR will cause more deferrals than IVUS. We just went over the study, the Flavor trial, which compared IVUS guidance pre and post versus FFR guidance pre and post, and they found that the clinical outcomes were identical, but that FFR tended to defer more lesions.
Yes.
And so around the world, that's considered an advantage because you're utilizing fewer stents, you're not going to have the stent thrombosis issue, medication-wise. Obviously, from an individual reimbursement standpoint, from the US standpoint, that may be a disadvantage if you're stenting less. But I think from the standpoint of good clinical care, patients would certainly be better off with a stent that they needed rather than a stent they didn't need.
Exactly.
So I think objectively, FFR is probably still better in stenting the things that we need to, while IVUS and other imaging are good at deploying the stents afterwards.
So I just want to dive deep a bit into Flavor. So these patients had intermediate lesions in the 40 to 70 range.
Right.
Yeah,
right.
Angiographically.
Yeah.
And they randomized to imaging versus FFR. So, but again, I mean, differing is not a bad thing then, because the patient did the same.
Correct. So, deferral is safe, and that's what they established in Flavor trial that was presented just 2 months ago at ACC. And so, they took 3,600 patients, a very large study comparing IVUS pre and post for optimization and guidance versus FFR pre and post for optimization and guidance. Again, this is not how people clinically use FFR right now. This is FFR post PCI. Similarly, it's not necessarily how people use IVUS as well. Most people use it after the stenting. This is IVUS pre. So it's very interesting that this data suggests that you could use either imaging or physiology for both pre-lesion assessment, pre-PCI lesion assessment, and for post-PCI optimization.
Yeah.
And this is something that we've always thought about. The presumption has always been that FFR and physiology is better for identifying the lesions that need to be stented, and then that IVUS would be better at stenting, identifying the optimization. I still think that's probably true, but at least this clinical study that was relatively large couldn't show a difference in MACE. And so I thought that was a fascinating study that I'm glad that was presented at ACC.
Yeah. I just want your comment on the FAME-3 trial. It depends who you ask. It's a positive trial, it's negative trial. I don't like using positive, negative because everything's good. but how do we implement this in our practice?
Yeah, so just to reiterate, the
Please.
FAME-3 trial, PI was Dr. Bill Fearon, and I didn't comment much in my talk, but essentially it was a trial of stenting versus surgery for high-risk, high-complexity multi-vessel disease. And in that setting, the hope was that FFR-guided PCI, multi-vessel PCI, would be superior or at least non-inferior to a CABG strategy. And it turns out that that wasn't the case, at least by the way they measured their definitions of MI. In that particular patient population, it was a pretty high syntax score. That patients with CABG did better. And the reason for that, most likely, was that the severity and complexity of the disease was higher in that cohort.
Right.
Now, in a less complex cohort, if they divided into tertiles, and the low syntax score group at least came closer to non-inferiority. So I think there's still an opening, but essentially it was a redo of the syntax trial with FFR, and FFR is an application, right? This is a use of FFR. It's a tool, and this particular application wasn't enough to overcome the inherent benefits of complete revascularization with surgery compared with a multi-vessel stenting approach.
And just for the audience, the FFR was done just pre. They didn't do FFR after.
Right, correct.
One trial I think is enrolling now is GPS.
Define GPS.
Define GPS. Yeah. This is for post-PCI FFR.
Right. IFR. Yeah.
So the cutoff is 0.94, if I remember. Just they want it to be above that threshold.
You've got me there. I think it's either, remember, it's an IFR cutoff, it has to be at least above 0.89.
Yeah. But
I believe you're correct. It's either 0.93 or 0.94.
Yeah.
And there's a trial of using IFR pullback with co-registration post-PCI to make sure that we don't miss any lesions. As we recall from the DEFINE PCI trial, 20-25% of patients will still have angina and a ischemic lesion after successful stenting angiographically. And so DEFINE PCI identified that this is an issue, and now DEFINE GPS is actually testing whether that pullback and then optimization by IFR, would that be better than just angiographic alone. So,
and do you use that in your practice now?
Yeah. Oh, yeah. I mean, it's thoroughly integrated in our workflow to have pressure pullbacks, and doing post-PCI IFR is very straightforward. And
you have the wire, you worked on it.
Right.
Why not just reconnect it again and get a reading?
Exactly. And the newer wires, the Omni wire, is very user-friendly.
Yeah.
It's not too banged up after interventions.
Correct. So, it's more durable and connectivity not a problem.
Right.
Well, Dr. Seto, thank you so much for your time and for your insight on the physiology for coronary. Please watch his videos and others on CVI YouTube channel. This is Chadi Alraies from Denver, Colorado. Thank you so much.
All right. Thank you.